This is the first lecture for NUR 121, Topic 1, Oxygenation. Now I hope that this time the sound quality is a bit better, so let's see how we go. For this topic, as you can see, I've cut out some of the readings for you, so we will focus to start off with on the anatomy, just like we did last semester. So usually anatomy first, and then we move to the function, the physiology. We distinguish between the upper and lower respiratory system, and then look at the microscopic and macroscopic anatomy of the lungs, and particularly the pleura as well. And then we look at how it actually works. So how do the lungs move the air in and out, and how do the gases then get into the blood and the tissues and back again, and how do we transport the gases in our blood. And finally we look at the control of respiration. Now before we get started on the actual content from the textbook, I would like to cover briefly some of the physics laws. They're quite important to understand because they relate to how our lungs work, particularly how the gases work with getting in and out of our lungs, and also how they can get transported around the blood and how they get into the blood or out of the blood as well. So we're looking at 3 different laws, and as promised, I will always provide the learning outcomes now for the lecture as well. So we're looking at Boyle's law, Dalton's and Henry's laws. Starting off with Boyle's law. Boyle's law is actually quite an easy law to understand. It talks about volume and pressure in gases. Now remember, gas is made up of different molecules. So if it's oxygen, it's made up of oxygen molecules. If it's the air that we breathe in, it's actually a mixture of different gases, nitrogen, oxygen. We've got some other gases in there like helium, but the majority is nitrogen, and only about 21% is oxygen in our air that we breathe in. So those molecules take a certain volume, and that depends on how much pressure I put on there. If I put air into a gas bottle so that you can use it for diving, for example, we compress that air a lot to put a lot of air into a small bottle. So a lot of pressure, which you can see here on the pressure gauge, at very reduced volume. The opposite is the case if I blow up a balloon, and the more I blow up the balloon, the bigger it gets, so the volume increases and the molecules spread out, and that reduces the pressure. So pressure and volume are always constant. If I increase one, the other one will decrease, and vice versa. That is the case if the temperature remains constant. So we'll just assume that. How does this relate to our lungs? Well, it's quite easy. If you think about the lungs, they're suspended in our chest, and they're kind of attached via the pleura to our rib cage, and the ribs around it keep it provide a volume, and we can change the volume of our rib cage, and the organ that does that is a muscle, our diaphragm, our breathing muscle. If we contract the diaphragm pulls down, and that expands the volume of our chest, and therefore the volume of the lungs. So increased volume means we've got a decreased pressure in the lungs compared to the outside air, and that will get the air to move in. It's always about concentration gradients. If we have higher concentration of something on the outside or on one side and less on the inside, then the particles of the higher concentration want to go where the lower concentration is. So we've revised that in this week, week 1, and that's the same case with gases. So this is how we get air into the lungs. Our next law is Henry's law, and that talks about how gases can dissolve in liquids. Now, you know that gases can dissolve in liquids because some of you've got a soda maker and you push CO2 into water. So we can get gases to dissolve in liquids, but that depends very much on the pressure. The higher the pressure, the more gas molecules we can dissolve in a liquid. So the pressure of those gas molecules we also call partial pressure. So that's why the volume is proportional to the pressure. So the higher the pressure, the more we can dissolve. How does that relate again to our lungs? Well, we get the gases from the lungs across into our blood by dissolving them in water or in our blood at some stage as well. So the water that lines our little lung alveoli, the little sacs in the lung that where the gas exchange happens. If we are very, very high on a mountain, like Mount Everest for example, the pressure of oxygen very high up is much, much lower than it is at sea level. So the partial pressure is much, much lower. So that makes it much harder to get the oxygen into the blood. Whereas the opposite is the case when we dive. The partial pressure of air increases as we dive further down, which makes it easier to dissolve in the blood. But I said before that unfortunately a lot of the majority of the gas in the air that we breathe is actually nitrogen. So we get a lot of nitrogen dissolved in the blood, and that can cause problems if you dive up too quickly. You get the bend, as they call it. The last law we look at is Dalton's law, and this is also fairly easy, it's fairly straightforward. It just says if we have a gas that's made up of different types of gases, like our air, we've got nitrogen, we've got oxygen and some other bits and bobs. So the percentage of the gases in that whole gas is related to the different pressures. So oxygen 21% would have 21% of the total pressure of air. Nitrogen about 70%, or a bit more than that, 78%. So that would be the pressure, the 78% of the total pressure. And all the pressures add up until we get the total pressure of the gas mix. How does that relate to our lungs and oxygenation? Well, that principle gets used when we have gas exchange happening from the alveoli to our blood, and also when we get to the tissue, how the blood releases the gases into the tissue. It'll become clearer as we go further down, so don't panic yet. I just mentioned with oxygen we need to look at what's the pressure, the partial pressure of oxygen when we breathe it in our air that we breathe in. As I said, we've got 21% of oxygen in our air. So the normal pressure of air at sea level is 760 millimeters mercury. 21% of that is 159, or often we say 160. So the partial pressure of oxygen in the air that we breathe in at sea level is 160 millimeters mercury. So remember that. Okay, so now we get into the nitty-gritty of things. First of all, we need to look at how does oxygenation happen. So oxygenation is the whole process of breathing in and eventually having oxygen available at the cells, and likewise getting rid of the CO2 from our cells and breathing it out again. Why do we need oxygen? Well, you remember from last semester, we need the oxygen for our cells in order to make energy, ATP. So remember, we do that together with glucose, or we can also use fatty acids or amino acids. And the most ATP, if you remember, gets produced in the mitochondria during the process oxidative phosphorylation or electron transport chain, and that requires the oxygen. So oxygen doesn't give us energy directly, but we need oxygen in order to make lots and lots and lots of ATP. So the intake of oxygen and breathing out carbon dioxide requires the lungs and also some structures to actually get the gas into the lungs or out of the lungs again. And it also requires good blood supply, because without blood we can't get the oxygen from the lungs into the blood, and vice versa, the CO2 out of the blood into the lungs to breathe it out again. So this is the whole process of oxygenation, and we look at that in more detail now. So this shows the various processes. Sometimes people also call oxygenation respiration, which is kind of the same, so it's like an umbrella term. It's a bit of a chaos with all the terminology, because you've got respiration, ventilation, breathing, oxygenation. So basically respiration, oxygenation gets used as an umbrella term. And it then breaks up into pulmonary ventilation, so our inspiration and expiration, or inhaling, exhaling. Then we have external respiration, which is the process of getting the oxygen from the lungs into the blood, and the other way around, carbon dioxide out of the blood into the lungs. That's kind of pretty much the same as internal respiration, just the opposite. So in the tissue, we want to get the oxygen out of the blood into the cells, and the carbon dioxide from the cells back into the blood. So external, internal respiration. And in between, we actually need to transport the gases. How do we transport them? Well, they're transported in the blood, but there's certain ways that we can transport them. So a very important fact to remember from this image here is that in the systemic circulation, so the blood that gets pumped out of the heart and that goes into all our tissues and cells, carries oxygenated blood in the arteries and deoxygenated blood in the veins. Now most people think that that is the definition of an artery and a vein. That's not the case though. The definition of an artery is that it is a blood vessel leading away from the heart, and the vein is a blood vessel coming back to the heart. Because when we look at the lungs, it's actually the opposite. We have a pulmonary artery going away from the heart, but that carries the deoxygenated blood that came back from the body and takes that to the lungs, where it gets saturated with oxygen and travels back to the heart, this time via the pulmonary vein. But this is now oxygenated blood. So the proper definition for an artery is away from the heart, and it is usually a much stronger blood vessel with a very thick layer of muscles, smooth muscle tissue around it, whereas a vein is usually a lot floppier and doesn't have as much smooth muscle around it, but has valves. So they're quite different, and we will talk about blood vessels in topic 2. Okay, so now we go into the anatomy of the respiratory system, and you can look at those learning outcomes. And here is the first one. So we have all the different structures. We've got our upper respiratory tract, which includes the nose, the sinuses next to the nose, and the pharynx. And then we move from the larynx onwards, we move into our lower respiratory tract, which, like I said, consists of the larynx, the trachea, which then splits up into your bronchi, and the area where it splits up is called the carina. Sometimes you might hear that. So when people get intubated, or if they inhale something, that often kind of drops to the carina. And then we have the right bronchus going here and the left bronchus going there. This would be where the heart is, so you can see that the left lung, only because it's smaller, only has the 2 lobes, whereas our right lung has 3 lobes. You can also see the pleura here, which is just like we had in the abdominal cavity, our peritoneum. Here we have the pleura. so one of those serous membranes, which consists of two layers, the outer layer, the parietal layer, which attaches to the ribs, and the internal layer, the visceral layer, which coats directly the lungs. And in between we've got a little bit, teensy-weensy little bit of fluid, like serous fluid, but it's only a tiny amount and only enough to keep the two layers of the pleura sliding against each other, allowing for movement. Now this is how our lungs are anchored to the ribs, and that's what allows the lungs to increase in volume when our diaphragm moves down. You can also see that each lung has its own pleura, which that is a good thing, because if one of them got injured, the other lung can still function. Now the pleura plays a very, very important role in ventilation. Without the pleura, it actually wouldn't work, and we look at that in a bit more detail later. Now here just some terminology you might hear. So we call the nares the nostrils. So nares with an E is both nostrils, with an I it's just one. Septum is something that you hear, so the internal division in the nose. The function of the nose and the sinuses is to basically just moisten and warm the air, and also to clean the air. So it filters the air, removes foreign particles, and also has an important role. It contains our olfactory receptors, so our sense of smell. This just shows how the nose and the pharynx are linked. So you can see this is our nasal cavity, and it leads into the pharynx, which connects it to the mouth, and you know the little uvula at the back there that dangles around there. We also have a connection to our middle ear through the pharyngotympanic tube, which in the olden days was called Eustachian tube. You might have heard that, and that's the one that you use if you equalize pressure, and you know, the one that clicks and rattles when you on the aeroplane or you're going up or down a hill. So to equalize the pressure between our nasal and oral cavities and the middle ear. Now we have a very large surface in the nose and the sinuses, and every time we have big surfaces, you know that that is there to absorb things or do certain things. Well, in this case, it's actually there to warm and humidify the air that we breathe in. Cold air and dry air is not very good for our lungs, so we need to humidify it and warm it, and you know how that feels if it's not done, when you get a cold and you have to breathe through your mouth. Not very pleasant. The mucosa that lines that cavity is respiratory mucosa, and it's made up of pseudostratified ciliated columnar epithelium. So we've got lots of cells in there, goblet cells and nasal glands that produce mucus, and the mucus contains lysozymes to kill certain things or digest foreign things, and defensins. Remember, that was like the body-own antibiotics. It also has the cilia, like the little hair that is on the outside of the epithelium, and their job is to transport the mucus and whatever gets trapped in it down our throat, so we swallow a lot of foreign objects and dirt and stuff together with the mucus, and it goes into our tummy and eventually we excrete it. Those cilia don't work very well when it gets very cold, so cold air make them very sluggish, and so some of the mucus can't get transported and we dribble out of our nose. We also have a very good blood supply underneath this respiratory mucosa, and that also helps with heating, because remember, blood is warm, so we heat the air, and that's why we get a lot of nosebleeds, because it's just so very well perfused. These blood vessels are also the ones that dilate when you have a cold, and that's what causes the blocked nose and the swelling. And decongestants, they basically lead to vasoconstriction. So the whole idea is big surface in the nasal cavity, including all your sinuses, to warm, humidify, and clean the air. The opposite happens when we exhale. So because of these funny gaps that you have here, or these incisions, well, or deep places called conchae, we also cool the air and take the water back out again before we exhale it, and that's just to conserve water. So you don't need to know the name of the individual structures, just keep that one in mind, pharyngotympanic tube and the uvula, because that's what gets used quite a bit. This here now is the pharynx, so it has 3 parts, and that's basically the area where our nasal area and the oral area combine, and we have 2 structures traveling alongside each other, our esophagus for the food and the trachea for the air. So the pharynx is when we still have a mix of both food and air, but then after the laryngopharynx we basically have a very clear distinction between the trachea and the esophagus. So the trachea more ventral, esophagus posterior or dorsal. And the pharynx also has another function apart from sorting out what goes where. So it'll make sure the food goes down the esophagus, and it will protect the airway when we swallow with our little epiglottis here. That shuts off the larynx and therefore the trachea when we swallow, and also helping with defending the body from outside pathogens that could come in with the air. So we have various tonsils, you can see 3 different tonsils that are part of the immune system, and they will assist the other protective mechanisms of the airways. Now the mucus, the epithelium, varies depending on where you are in the pharynx, but I wouldn't worry too much about which one is where. The only other thing I'd like to point out is that not only does the pharynx protect the airway from getting food into it, it also kind of shuts off here, so when we swallow we don't get food coming back into the nasal cavity. But you all know that if you giggle or do something silly and don't concentrate, then that can happen and you can have food, or particularly fluid when you're drinking, dribbling out of your nose. We've already talked about the importance of the swallow reflex and how that all needs to function very well, otherwise we might get food into our trachea, which can happen with stroke or head injuries, and often in older people as well. And dietitians, it's their job, and not dietitians, speech therapists will assess that. Just some landmarks that we can see from the outside. So you can see the cricoid cartilage down here, and the thyroid cartilage is the big blob that's up there. So it's this one here is your thyroid, the big one here, and then we've got the cricoid there. And you've also got your sternum here with the top of the sternum, the manubrium, which has this little notch at the top, which is called the jugular notch. Now, why are these landmarks important? Well, to start off with, if people have a problem with air intake into their trachea, they get what's called a tracheotomy, so a hole put into the trachea here, and a tube gets inserted, which can be hooked up to a ventilator. You can also do an emergency cricothyrotomy, as it's called. So if a person has an obstructed airway and you're in the middle of nowhere and you don't know what to do and it doesn't come out and you've got to get air into that person, you can basically punch a hole into that bit between the thyroid cartilage and the cricoid cartilage and put a hole in there and a little tube, and that's how air will get in. The other thing with the cricoid is that when a patient gets intubated for surgery or for whatever other reason, sometimes the doctor likes to have what's called cricoid pressure. So you basically push slightly on the cricoid, and that can help with getting the tube in easier or prevent aspiration. It's a bit of a dodgy area. Some people say it doesn't work, some people still like it. The other thing is, if you look at the neck, you look at, is the trachea straight and not deviated, like bending to one side? If it did, then that indicates that there's something wrong with pressures inside the chest. So one example could be a pneumothorax. And here is our different cartilages and the larynx. But like I said, don't worry too much about it. Just remember your epiglottis, your vocal folds, and the big cartilage is the thyroid cartilage at the front, and then our cricoid cartilage at the bottom. Here. And again, this is the front ventral, this is dorsal. So your epiglottis basically shuts off towards the back. This is what you see when you look through a laryngoscope. So you can see the laryngoscope up there. There's a light attached to it as well, so it will shine a light into it. The head gets tilted slightly backwards, and then the person who does the intubation can look at the vocal cords, because that's where you've got to get your tube in. That's how you've got to poke it through there. And a brief look here at the lining of the trachea and the bronchi. So if you compare it to the gastrointestinal tract, you can see some things that are similar, like we have a mucosa and the submucosa. So we have the columnar epithelium with glands interspersed, but the difference with the trachea and the bronchi is that we have hyaline cartilage here to strengthen it so that it doesn't collapse. We need to keep our airways open, so they need to be quite rigid, so we don't have muscles there like in our esophagus, for example, but we have cartilage there, hyaline cartilage. Moving on to the macroscopic anatomy of our lungs. So and the trachea and bronchi, so I already mentioned, they branch, the trachea branches off into the left and the right main bronchus, and then we have smaller bronchi, segmental bronchi or secondary bronchi, so first into the lobes and then into little segments, and then they branch off into our eensy-weensy little bronchioli, so they're very small. Now the right one here is kind of flatter, and if you swallow something accidentally or inhale something, not swallow but inhale something accidentally, chances are it will get stuck in our right bronchus rather than the left. The left is a bit steeper. The space of the trachea and bronchi is also called the dead space, because this doesn't participate in the gas exchange. That actually happens in the lung tissue. So this is only the tubes that transport the air to the lung tissue. So there's no gas exchange, that's why we call it the dead space. And that's about 150 mils of air with each breath. So all this we can see with the naked eye. Moving further down, so we look at the smaller structures. So you can see the little alveoli branching out, and they have these little grape-like structures hanging off their ends. They are called the alveoli, which basically means sac, air-filled sacs. And if you look at the alveoli, if we cut them open, you can see those structures here that kind of look like a hexagon. They're the individual cells. Then we've got some pores that let the air through, and if you look at it under a microscope, you can see that they are just air filled, so it's just the epithelium around it, and otherwise it's filled with air. Now, because we need to have gas exchange happening, we need, of course, the blood vessels very, very close to the alveoli, and you can see here how a whole net of capillaries surrounds the alveoli. This is where the gas exchange happens. So very similar to what happens in the nephrons, where we have the exchange between the filtrate, what becomes the urine, and the blood vessels. Well, here we have the gas exchange, the gas inside the alveoli with the blood vessels. Now, just to summarize again, the protective mechanisms we have in our respiratory system. We have the mucus, which acts like a trap. We've got, first of all, the nose hair, so that's actual hair, and you know that when it grows out of the nose, which is not very pleasant. They're called vibrissae. And of course we have the cilia on our little epithelial cells, so they transport the mucus with the dust and dirt and whatever gets stuck in there. We can also sneeze or cough and get rid of something foreign very quickly, very rapidly. I mentioned the defensins and the lysosomes. The other important thing is we actually have some local macrophages in the alveoli that will attack any bacteria or anything foreign and gobble it up. And I've mentioned the tonsils that are part of the lymphatic system. Okay, so now we know the anatomy, so now we want to go back and look at how does it all work, how does oxygenation happen. And we start off with ventilation. So these are the learning outcomes that refer to the ventilation. And here we are. So going back to Boyle's law, remember that increased volume will lead to a decreased pressure. So because of the pleura, and we have the pleura here as this grey structure, and it's actually not that thick. It's very thin, and the two layers basically are on top of each other with just a little bit of fluid in between. This is just to illustrate. Like I said, the pleura is stuck to the thoracic wall, and when we move our diaphragm, when we contract our diaphragm, it moves down, which opens up the ribs and also moves the whole ribs down a bit, and that expands the volume of the lung. So that means that the outside air has the pressure of 760 compared to the inside pressure, which of course is going to be lower. So that draws the air in. But understanding the pleura, you have to understand that because we've got fluid in that pleura and the two layers are attached to each other, that in itself produces a certain pressure, which is called the intrapleural pressure. And that is always a little bit less than the other pressures. It's always about 4 millimeters of mercury less. So that's why we call it minus. Because of this negative pressure, that also keeps the lungs from collapsing. So it keeps the lungs open, because the lungs really would like to collapse if they're not attached and if they're not kept open by the attachment to the pleura. So because of the decreased pressure, like I said, inside the lungs, the air will draw in. So this inhalation is actually an active process. We have to contract our diaphragm. And once the diaphragm relaxes, the volume decreases, so the pressure increases, and that pushes the air out again, which that is a passive process. So with each inspiration, we actually draw in about 500 mils of air, but remember we've got about 150 mils of dead space, so only about 350 mils reach the lung tissue and take part in the gas exchange. Okay, so again, the intrapulmonary pressure is the same as the alveolar pressure, which is lower than the pressure outside of the air during inhalation, because we have increased volume. That's in inspiration, so when we breathe in. The intrapleural pressure is the pressure, like I said, between the two layers, and that's always less, 4 millimeters less than the pulmonary pressure. And that's, like I said, due to the surface tension of the fluid, and also because the lungs are pulling, they want to collapse. So that holds it open. And both of them together are what's called transpulmonary pressure. So the pulmonary pressure minus our intrapleural pressure, which provides a constant pressure both during inspiration and expiration. So that keeps the lungs and therefore the alveoli from collapsing. If we didn't have that, it would be the same as when you blow up a balloon and you let the air out again, the whole balloon collapses. And it takes a lot of effort and work to overcome that initial inflation of a balloon. The lungs don't need that because they will always stay open. They will never collapse because of our pleura. When the pleura gets damaged, lungs will collapse, and that's of course detrimental to breathing. We can't breathe into a collapsed lung. The work is far too hard and it would cause too much of an effort. Okay, what are some factors that influence how well this whole ventilation works? Well, we have resistance in our airway because we have friction in the bronchi and the trachea, and that's due to diameter changes. So remember when we looked at fluid flow, we looked at how an increased diameter causes an increased flow. If I constrict bronchi, then that will reduce the flow and also increases the friction. So we call that an increased resistance. Now that happens mainly in the medium-sized bronchi, so not in the trachea and not in the bronchioli, but in the medium-sized bronchi. We actually use this actively. We can dilate the bronchi to get more air in, and we can also constrict it. The other thing is our alveoli. Like I said before, they're coated with water, and the water would really lead to the collapse of the alveoli because water wants to take the smallest surface possible, which would lead to a collapse of the alveoli. But we have something that's called surfactant, which acts a bit like dishwashing liquid. It reduces that surface tension, and that prevents the alveoli from collapsing. So if babies are born premature, they don't have surfactant yet, or not enough, and we need to give surfactant because otherwise their lungs would collapse and they couldn't, or their alveoli would collapse, not the lungs, sorry, just the alveoli, and they wouldn't be able to breathe. And this just shows how these medium-sized bronchi, when they constrict, they provide much more resistance, and you can see that when you get to the bronchioles there is really no resistance at all, which makes sense. We don't want the air to be impeded when it gets to the bronchioles because we want to have good gas exchange happening. The other thing is also, we call the area of the trachea and the bronchi is our conducting zone, so it's not participating in the gas exchange. The gas exchange happens in the alveoli, and that's the respiratory zone. Now, in order to diagnose how well the lungs work, we can look at different volumes, and you can look at those here. Like I said before, a normal inspiration expiration is about 500 mils, and we call that the tidal volume. However, we can breathe in as much as possible, and that can even go up, as you can see, up to 6 liters. So we can breathe in up to, about 3 liters more. Likewise, we can also exhale much more than just your normal breathing. But no matter how much we exhale, there's always a residual volume that will stay in the lungs. And you can see that's about 1 liter. So we can never get rid of that. That has to stay there to keep the lungs open, to keep the alveoli open, not like a balloon where it collapses completely. So you can see those volumes then get put together and get different names for capacity. And you can see that the vital capacity, which is an important one, is basically maximum inspiration and maximum expiration minus we don't have that residual volume. That would be our total lung capacity if we add that. This is the same, just as a table to show you the different volumes again and what are they called, and you can also see that there is quite a difference between males and females, not in the tidal volume, but when we look at our reserve volumes, you can see there's a huge difference between males and females. Some other parameters that we measure in the spirometry, and we will be doing that in the tutorial. So FVC is the forced vital capacity, so that means a very deep or like a maximum inhalation and then a very rapid forceful exhalation until you can't get any more air out. So that's our forced vital capacity. And then we've also got something called FEV, which is the forced expiratory volume. Now that's the amount of air that we blow out. Remember, we do it rapid and forcefully, that we blow out particularly after 1 second. We call that FEV1. And that's the majority of the air that we breathe out very quickly, very rapidly in that first second. Should usually be about 80% of the whole of the FVC. After that second, we keep exhaling and we still get rid of the rest of the 20%, but 80% we get rid of in the first second. And I've talked about the dead space, 150 mils. That increases if we have any blocked areas in the lung, like alveolar are blocked, because then they don't participate in gas exchange either. So anytime we don't have any, we have a structure not participating in gas exchange, we call it dead space. This is the example of one of those FEVs, how that looks. So like I said, in the first second you exhale 80% of what you totally exhale. So in the case here, 4 liters, we exhale 3 liters in the first second. If someone has asthma, then that changes. They can't breathe out that well because we call that an obstructive lung disease. So it's not as easy to exhale air. There is an obstruction, usually from the constriction of the bronchi. So we've got more resistance, and therefore it takes longer to get rid of those 4 liters. And depending on how severe the asthma is, that curve might even be flatter. Okay, so that was ventilation. Let's move on to the next bits, our external and internal respiration. And we pool them because they're pretty much the same, just the opposite. Here are your learning outcomes for that. So before we look at how it all happens, we need to quickly go back to our anatomy, and this time microscopic. So look at our alveoli. So this here is one of those little alveolar sacs or balls or grape-like structures. And you can see that we have the alveolar cells in there. We have 2 different types of cells, type 1 cells, which are the ones that do the gas exchange, and we also have type 2 cells. They produce the surfactant. And you can see our little macrophages, and of course lots and lots and lots of blood vessels around here, because that's where the gas exchange happens. Now here's our capillary red blood cells, and here is our type 1 alveolar cell, and you can see that the 2 basement membranes are fused, and that's where our exchange happens. So a little bit like when you remember in the nephrons, we had the same thing where we had a basement membrane where the filtration happened, or in the tubular structures where the capillaries are very close to the tubular structures and there is exchange happening backwards and forwards. Now, the exchange of oxygen and carbon dioxide, both in and out, is a passive process. It just happens merely via diffusion because we have different pressures in the blood as compared to the alveolus of those 2 gases, 2 different partial pressures. So that enables diffusion, which is a passive transport. Now let's see how that happens. Okay, so let's start in the lungs. Here's our outside air. Remember I told you it's got 160 millimeter mercury pressure, partial pressure, the oxygen in there, because it's only 21% of 760 millimeters mercury, which is the pressure of the air as a whole. So oxygen 160. We hardly have any CO2 in our inspired air, so we can kind of forget that. So then we move on into the alveoli. So now the pressures change. The reason they change is because in the alveoli we have a mix of air that comes back, so it's got CO2 in it, and so it's not the same as the inspired air anymore because it mixes up with the CO2. So our partial pressure of oxygen goes down, and of course our partial pressure of carbon dioxide goes up, 104 and 40. Now this air then gets transported out of the lungs in our pulmonary veins. Because it's got lots of oxygen in it, we call it oxygenated blood. Travels back to the heart, where it's then pumped into the body. So our left heart pumped into the body. Don't worry too much about left and right heart at the moment. We will cover that with our next topic. Okay, so oxygenated blood goes into our body. And it's pretty much still the same as what it was in the alveoli. We've lost a little bit of oxygen along the way, but don't worry about that. So roughly 140 still gets to our tissues. Now our tissues are crying out for oxygen because they've used up all the oxygen. So we don't have much oxygen in partial pressure in our tissues. We only have up to 40 millimeters. So there's a huge pressure difference between the two, and we know that if we have a gradient like that, oxygen will move from the high concentration to the low. So we're going to lose our oxygen into the cells, and likewise, because the cells have produced ATP, so they've had CO2 as a waste product, about 45 millimeters of mercury, which is higher than our 40. So we get CO2 diffusing out of the cell into the capillaries. The reason why we don't need such a big pressure gradient difference between the blood CO2 and the tissue CO2 is because CO2 dissolves in blood about 20 times more than oxygen. So we still exchange one molecule oxygen for one molecule CO2, but the pressure gradients are different. We need a lot of pressure gradient for oxygen, but not that much for carbon dioxide. Okay, so the cells now have taken up our oxygen, got rid of CO2, so now we travel along, going back to the heart with the deoxygenated blood, and you can see we've only got 40 now of oxygen, 45 of CO2. Coming back to the heart, that deoxygenated blood travels via the pulmonary artery back to the lungs, and in the lungs, remember we've got again a big pressure gradient, so we've hardly got any CO2 in the air that we inhale, so the CO2 diffuses into our alveoli, and we've got hardly any oxygen left in our capillaries here, so the air that we inhale has lots of oxygen in it, high pressure 160, so we get oxygen back into the capillaries and end up here again. The other thing to remember is that the uptake of the oxygen, so the blood that flows past the alveoli takes about 3/4 of a second to flow past. But in the first quarter, we almost have most of our blood saturated with oxygen. So that means we've still got about half a second left where Ideally, we could still add more oxygen if we needed to. So if our blood flow increases when we do exercise, we've got enough time for all the blood to be oxygenated during that 1 second. The other thing that's important to remember is that our lungs will always try and match the blood flow in the capillaries to what comes in to the alveoli, how much gas or how much oxygen comes into the alveoli. And that makes sense because that will provide the optimum saturation of blood with oxygen and the optimum getting rid of CO2. So if we have an increased ventilation, so we breathe a lot and we get a lot of oxygen in, but we don't have good perfusion happening at the time, our arterioles will dilate so that they can take up more of that oxygen that we breathe in. Likewise, if we have an issue with we can't get a lot of oxygen in and our arteries or our capillaries, particularly our arterioles, are dilated, then they will constrict to reduce the perfusion to match this again. So that all depends on the pressures as well. So remember we said higher volume is often with reduced pressure. So it's much harder for the gas to get into the capillaries because we don't have as much pressure. If they dilate, that makes it a lot easier. Now this whole idea with ventilation and perfusion, I've said before, in order to have oxygenation, both parts have to work. We have to have gas coming into the alveoli, and the alveoli have to be functioning, and we have to have the blood vessels around, and they have to be functioning as well. So we call that the V and Q ratio, ventilation and perfusion. They have to work together. So in the ideal scenario, we have air coming in into our alveoli, and the capillaries, the blood flow happens very nicely, picks up the oxygen from the, and therefore deoxygenated blood becomes oxygenated blood. Now sometimes things can go wrong and our alveoli could be blocked. So for example with mucus. So we still have the blood flow happening, but we don't have any gas exchange happening. So those alveoli that are blocked with mucus, like in pneumonia for example, they have the blood flow but the blood doesn't get oxygenated. So we're basically mixing oxygenated with deoxygenated blood, which leads to less oxygen, and that's what we call hypoxemia. So less oxygen in the blood. We could also have another scenario. So we could have problems with our perfusion. So that means the alveolus is working fine, getting the air in, but we don't have any blood flow to that particular alveolus. And that could be caused, for example, by a blood clot. So you might have heard of pulmonary embolus, where a clot is stuck in the lung. It's stuck in the blood vessels or the capillaries of the lung. So again, this won't get oxygenated because we don't have blood flowing past that alveolus properly. So some of the alveoli will not participate, and that means on the whole we again end up with less oxygen in the blood. So we end up with hypoxemia again. In the very, 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 very worst case scenario, when the alveolus is completely blocked and we have many, many, many alveoli that are blocked, we basically just circulate the blood around the lungs or one lung area, and it never, ever, ever gets oxygenated. And that's what we call a shunt. Now, if that happened to a very, very large area of the lung, like a whole area of the lung, there would be no gas exchange to the blood, then that would be very critical. So if you had a blood clot, that blocked off, no, if you had something that would knock off, like a mucus plug that would knock off a whole area of the lung, then that would be very, very critical and potentially lethal. Okay, so we've got the blood exchanged in the tissues, in the lungs. So now we need to look at how do we transport it around the body, and we do that now. Transport of the blood. So first of all we look at, transport of the gases in the blood. So first of all we look at oxygen. Now oxygen, like I said, doesn't dissolve well in fluids. So only about 1.5% is dissolved in the actual blood. The majority, 98%, 99% is bound to hemoglobin. Hemoglobin, we look at that again in more detail next week when we look at blood. But it's a molecule in the red blood cells that takes up, that consists of different parts. One part is called heme, which needs iron. That's why we need iron. So the heme binds the oxygen. There's 4 hemes within one molecule of hemoglobin. So we can theoretically bind 4 oxygen molecules per hemoglobin molecule. When that's bound, we call it oxyhemoglobin. And when all 4 of them are bound with oxygen, it's saturated. Now there's a typical curve how the hemoglobin and the oxygen attach to each other. I show that to you in a tick. It's an S-shaped curve, and it means that we get a high saturation of the HB even when we don't have a very high pressure of oxygen. Now that makes sense because we want to make sure that we always have enough oxygen in our HB to go to the tissues, even if there is not a lot of oxygen available in the air that you inhale, or not a high pressure of oxygen. So as we said before, in the alveoli we roughly have a pressure of oxygen, partial pressure of oxygen of about 100, and that means our hemoglobin is saturated 98%. That's what you see when you put an oximeter on. Now deoxygenated blood still has a lot of oxygen hanging onto the hemoglobin, about 75%. So that means even if we don't have our respiration working, as long as we've got circulation of that blood, we still got quite a bit of oxygen that can go around. So that's what we use in CPR. We don't necessarily have to ventilate to start off with. As long as we keep it circulating around, we can still get some oxygen to the tissue. Now there are various factors that change how easily the hemoglobin picks up oxygen. That's called the affinity. So high affinity means hemoglobin picks up a lot of oxygen. Low affinity means hemoglobin wants to drop or get rid of oxygen. And some of those factors are hydrogen ions, so the pH, BPG, which that is a byproduct of metabolism in the red blood cell, temperature, and also the partial pressure of carbon dioxide. If all of these are high, HB will drop off the oxygen much quicker, so it will offload a lot of oxygen, has reduced affinity. That's what we call the Bohr effect. Now we look at that in a tick. So first of all, this is our hemoglobin. So these are the heme parts that bind the oxygen. And like I said, we talk about that next week, next topic. So this is that curve I was talking about. Okay, here's our normal curve at body temperature. So you can see this is the percent of saturation that we achieve, and this would be our oxygen concentration. So you can see that the hemoglobin picks up oxygen very, very quickly, and we get saturation very, very quickly of 98%. Now, some of the effects, like I said, is pH and the partial pressure of carbon dioxide, and also temperature. If we have a fever, a high temperature, our cells need a lot of oxygen. So we want the hemoglobin to not have that much affinity for oxygen. We want it to drop off the oxygen easily in the tissue. And that's what happens here. So the shift to the right means the hemoglobin doesn't have as much affinity and will drop off oxygen much easier. The same right shift happens when we have increased carbon dioxide, which also makes sense. If we have increased carbon dioxide, that's probably because our cells are very active. They produce, for example, muscle cells, they produce a lot of waste products, so carbon dioxide. So we need, again, more oxygen in those tissues. So we want the hemoglobin to get rid of the oxygen much, much easier and pick up the carbon dioxide instead. So that's what's called the right shift. The opposite is the case, as you can see here, with cooler temperatures or with decreased carbon dioxide. We'll talk about that in the tutorial as well. Now with carbon dioxide, it's a different story. Carbon dioxide, I said to you, is much, much easier dissolved in fluids, so about 10% travels dissolved in plasma. Only about 20% bind to hemoglobin, and not that heme part where the oxygen binds, but the other bits. So remember, hemoglobin can transport carbon dioxide and oxygen at the same time. Once it's bound the carbon dioxide, it's also called carbaminohemoglobin, but don't worry too much about that. The majority of our CO2, though, doesn't travel dissolved or bound to HB. The majority travels as bicarbonate. Now, we talked about bicarbonate in the revision week. So the CO2 goes through this equation with water, carbonic acid. Carbonic acid splits very easily into hydrogen ions and bicarbonate ions. So this is how most of our CO2 travels in the blood, and that's very handy because that means it at the same time provides the buffer in our blood. So very smart solution of the body. Now, one other thing to remember is this equation happens quite easily, but in the red blood cells it happens really, really fast because there is an enzyme to help it, and that enzyme is called carbonic anhydrase. So that makes sure that as soon as the CO2 comes from the alveolus into the blood, gets picked up by the red blood cells, straight away this reaction happens and we change CO2 into bicarbonate. The Haldane effect is if we have a decreased partial pressure of oxygen and decreased saturation with oxygen of the hemoglobin, that will increase the capacity of blood to carry CO2. So it's kind of the opposite of the Bohr effect, is the Haldane effect. So those two names, you might come across them in different scenarios as well, particularly when we look at ventilating patients and also with acid-base balance. Okay, so finally we need to look at how is it all controlled. So respiratory regulation, we have neural control, so the nerves will control it, and we have just like we have a temperature center in the brain, we have a respiratory center in the brain, and it sits in the medulla, which is the top part of our spinal cord, and a bit further up the pons. That's the brainstem area. We talk about those in more detail when we look at the neurological system. Now these can get knocked out, for example in spinal injuries and head injuries, so that's why you can stop breathing with a high spinal injury. And they regulate the rhythm of the breathing. Usually we say inspiration takes, like normal inspiration at rest, takes about 2 seconds, expiration 3 seconds, and that kind of leads to our normal respiratory rate of 12 to about 16 per minute. Now this respiratory center also gets knocked out by too many opioids, morphine or heroin for example, and alcohol. So that's why intoxication with some of these, if it's too much, it actually is really, really dangerous, and particularly if you combine them, because it might knock off your respiratory center and you basically stop breathing. The nerve that innervates our diaphragm and the intercostal muscles, which are also responsible for making the chest wider when we breathe in, is the phrenic nerve and the intercostal nerves. Now the phrenic nerve comes from the spinal cord at the level of C345. So we say C345, keep the diaphragm alive. If you have a spinal cord injury at that level, which is lower than knocking out the brainstem, if it's lower here, that also causes problem because your diaphragm won't be able to constrict because the nerves don't send the message. This just shows you, this is the spinal cord and the top, the medulla and the pons, so this is where our respiratory centers live. Don't worry about the VRG or DRG, just know that that's where our respiratory centers are, and this is our phrenic nerve that controls the diaphragm, the contraction of the diaphragm. Now, what triggers the respiratory center to work harder or work less? We have a feedback mechanism, negative feedback mechanism, and the main trigger for that is our partial pressure of carbon dioxide in the arteries. That gets measured in some, like particularly our carotid arteries. They will measure the partial pressure of carbon dioxide. If that goes up, that will increase the pH in our cells, particularly in the brain, because we produce, CO2 will split into bicarbonate and lots of hydrogen ions. That gets measured in the brainstem and will cause a response in the respiratory center. We also have some other chemoreceptors that measure that as well, again in the carotid arteries. And what happens is the respiratory centers in the medulla will trigger the respiratory muscles to work harder, ventilation will increase, and we breathe out more CO2, and therefore our levels and the pH return to normal. Very, very important feedback mechanism. So most people think if we have oxygen, not enough oxygen, we will get our respiratory center triggered, but that's not true. It actually is the partial pressure of carbon dioxide, because that's also related to our pH. Eventually, if our oxygen levels drop too much, that will also trigger our respiratory center, but not to start off with. The biggest influence is partial pressure of carbon dioxide in the blood. And that was it for today. See you in the tutorial.